Hello.
Hi.
On this episode of Facts Friday, we're pleased to welcome Dr. Cheryl Barnabe, Associate Professor, Departments of Medicine and Community Health Sciences at University of Calgary, and Senior Research Scientist at Arthritis Research Canada. Dr. Barnabe is one of Canada's leading researchers focused on identifying and resolving health system care gaps for Indigenous patients. Dr. Barnabe, thanks for joining us today.
Well, thanks so much for having me.
Before we started, you let me know that you've been one of many rheumatologists across Canada who've been serving on the front line during the COVID-19 crisis. Can you tell us a little bit about your experience and what you've heard from other rheumatologists?
I can address it from the fact that I've actually been very fortunate not to have been deployed directly into a COVID ward situation. I really give credit to my colleagues. Several were the first ones to put their hands up and say they wanted to be part of this response. Some of us don't have as much comfort with inpatient medicine as we might have used to, and also have concerns at home where it may not just be possible to step into those situations without knowing that there is good protection for healthcare workers, good preparatory training and that sort of thing. And so one of the other really important elements of a pandemic response is to make sure that you don't lose ground on chronic conditions that are usually managed outside of hospitals, because if you're not addressing them at any time point, they will get worse. And then that could trigger more people having to come to hospital for non-COVID reasons. So I feel really strongly about that. We needed to continue with our usual rheumatology care and opted instead to help support our team here in Calgary with additional rheumatology coverage, so that people that were willing to put up their hands and say, I'll go do a COVID shift, could go and do that, or do administrative roles that they had to do to keep all the different pieces running in our 5 facilities in the city. So it was a very strange hospital scenario to walk into, though, to do some of those inpatient consults. At first, every hospital had a little bit of a different interpretation on the rules, and in some situations you wouldn't even know there was a pandemic going on. It felt just as chaotic and cramped and scuzzy as usual. And then in other situations, it was completely cleared out. People were really watching around touching of keyboards and making sure you wipe them right afterwards. And then I think you just had a different sense of fear, even just moving around the city and to different places during that time, because it was so silent. And yet you didn't know who might be sick and who might not be sick and what you were exposed to at work. So that's some of the scenario, but huge kudos to the rheumatologists that volunteer and who are doing shifts, as well as to the phenomenal work by public health, which really averted such a disaster for us.
That's a very interesting behind the scenes glimpse. I think, in the outside world, we've heard it's all hands on deck, but to really understand that from our community, rheumatologists like you are being asked to move from a clinic or from a lab back into a hospital to be on the front line is really incredible. Thank you and everyone else for your service. And that's why we're banging pots at 7 o'clock every night. So I'll be thinking of you and your colleagues tonight.
Thank you.
We want to focus the remainder of our talk today on your expertise and knowledge of healthcare delivery to Indigenous communities and underserved communities. Many of whom, as we know, are at a higher risk of COVID-19 because of their underlying medical conditions. So I guess I just want to first start out, if you can give us a snapshot of what has the reality been like for First Nations, Inuit, Métis communities during the last 3 months, during the pandemic, and what do we know about cases and confirmed incidents of COVID?
Yeah, I think the communities, it's really scary to undergo a pandemic at the best of times, but certainly pandemics have been linked to mass extinction or near extinction of many communities. So I think there's a re-traumatization process that goes along. And then some of the things that happened even with H1N1, where instead of sending supplies that would be helpful to prevent contagion, people were receiving body bags instead. And so I think every pandemic can be really, really a struggle. But the communities are constantly in a state of emergency, whether that be from an opioid crisis, whether that be from a housing or water safety crisis, whether that's from natural disasters like floods or fires. And so what we've seen here is that the emergency management system runs constantly, and so it was ready and primed, and people are pretty well versed in what to do to respond. Here in our province of Alberta, so far, there's been one single case up in a northern reserve. There's a small contained outbreak in one of the other southern reserves. And we know that northern Saskatchewan has been particularly affected. There's certainly cases scattered throughout other reserves. But as far as we know, there hasn't been mass devastation in terms of numbers of people affected or dying yet from COVID-19 in community. One of the big challenges is actually that we haven't been collecting any information about ethnicity of the people that are contracting COVID. And it's knowing that 60% of the Indigenous population lives in this urban setting. We actually have no idea how many people might have been affected or how many deaths proportionally would be happening in First Nations, Inuit, or Métis people. So we have some lack of data for, or like total lack of data for urban people. And then we know that there are a few hot spots in different communities, but so far, not the mass numbers that we would worry about.
Does physical distancing pose any unique challenges for these communities?
Absolutely. So we have multiple reserves where we've got 12 to 16 people living in maybe 600 to 800 square feet. And so if someone were to fall ill in the household, then we would expect everybody to have it, especially with the delay from from exposure to symptom onset. It's pretty hard to control. So some of the response has been to free up emergency hotel rooms for community members that they can go and stay in. Some of the other responses in the urban setting have been to create, again, aside from hotel housing, but in homeless shelters, moving those to larger facilities so that we can maintain physical distancing practices. I think the other thing too is that some people are very, very isolated on a good day. So they live quite far away from others, and that physical distancing has resulted in even less contact, and so it's created really isolating situations for some people that I've been speaking with.
There are guidelines that the Canadian Public Health authorities have issued as it relates to, long-term home facilities, nursing homes. I'm sure those are being applied and followed in the Indigenous communities. I'm wondering if you can describe to us, though, maybe sort of some made in community responses to challenges. We've talked about the physical health of people. What about mental health?
Mm-hmm. I think the really nice thing that I've been noticing within the different communities that I'm working with or a member of is that the online connections have actually really exponentially grown. So there's online beading classes, online, kitchen party like the music jam, learn how to play an instrument, learn your language. All of those things have moved online quite rapidly. And so I think there's a really nice reconnection to culture that's happening through this. I've been leading, along with some of my colleagues, a weekly connection circle with elders for our Indigenous graduate students. And so the elders have been very nimble at moving online, and it presents a bit of challenges with usual protocols, but they're very understanding of that we're in a very weird, strange time where we have to work around some of these. I've also heard of many people stopping to take care of each other, and so food being distributed to elders and people with disabilities who are isolated in their homes, quite remote from being able to access grocery stores. And a lot of people, with all the time that they have with their children, the time that they have away from the work setting, have had a great chance to reconnect with the land and really be families. So I think there's so much strength and resilience that's actually emerged from this, which is just, it's absolutely perfect. It's what we need to see.
ACE's understanding is that virtual care and telehealth has been in use in these communities a lot longer maybe than other urban centers in Canada. What is the state of that telehealth and virtual care? How is it being used during the pandemic? But I guess more importantly, what impact do you think this would have in terms of the long-term delivery of health to Indigenous and underserved communities?
Mm-hmm. Yeah, there was certainly a huge investment by the federal government within the past decade in telehealth networks out to different Indigenous communities. I've been a part of giving lectures and seminars to different health centers or attending a health fair virtually in the past to facilitate a broader audience, or perhaps facilitate bringing in people who normally wouldn't. Some of the colleagues, particularly in British Columbia, have been extremely nimble with virtual health, and as well as some of the colleagues in Ontario. And I think there's some of us like me who really value being able to be in community and who've been dragging their feet on virtual health, to be honest. And we know too that a lot of the patients have difficulties with access to things that we take for granted, like internet and cell phones. So people that run out of minutes, right, because they're using a pay-as-you-go phone, you won't be able to contact them until they have enough money to get the minutes back. So we've had seen those challenges in the past, and being in community seemed a good way to resolve those, because people knew you were there that Thursday, they could pop in if they needed something. But I think now the opportunity is that this places a focus on more technology in the home. So rural internet will probably improve as a result of this. Certainly physician resources to do this outside of health facilities, because that is one of our limitations, is telehealth hasn't been funded unless you're actually the patient's in a health facility that's approved and you're in a facility that's approved using an approved connection. I think we've just blown all of those barriers down. Like, let's make it simple to connect. And then hopefully this will actually, an interesting idea that's emerged is just around how we could do our visits with patients with their primary care physicians present as well, so that everyone agrees to a plan, and we start being able to transfer educational teaching back to the family doctor, but also placing more of that focus on their relationship as a care team, because you might not always be available to. So I think this is going to just propel all of it. Funding models will have to follow, because it'll be hard to go back before a vaccine is developed. So I think this will be a fantastic step forward for Indigenous health in the entire country.
Well, it's interesting. I think ACE will like to talk to you probably further about that, because we not only educate, but we also advocate. And certainly I think when we think about what is the long-term impact, and we're all trying to guess right now how things are going to change in the new world post-COVID, this is a really interesting example where Canada has some unique circumstances, our geography and our population that's divided from urban to rural. there's a real moment here for potential and positive change that you've described. And yeah, I think we look forward to following up with you on that. I think we'd like to now just offer you, if you have any other insights you'd like to share, maybe some recommendations for us as we move forward. Anything else that you'd like to add?
I really appreciate the work that you guys do to bring this to everybody across the country. And I just encourage you all to stay strong together. That's what we can all do, is be together until we can be together physically again. So
fantastic. Canada strong. Thank you very much for your time today. Welcome back from the front lines. We thank you again for your service. And we welcome our viewers to tune in next week for more episodes of Arthritis at Home. Thanks, Dr. Barnabe.
Thank you, Kelly.